background radiation. And nuclear medicine is a medical specialty that uses radioactive materials to diagnose and treat diseases. And it uses radiopharmaceuticals, which is composed of a molecule which determines the behavior of the radiopharmaceutical in the body, like DTPA, DMSA. These are different molecules, and these molecules are tagged with a radionuclide, which once entered into the body, it emits radiation, which can be picked up by an imaging device. And technetium 99 is the most frequently used radionuclide in nephrology. So we have to assess the kidney functions. We have got a spectrum of imaging modalities like ultrasound. It does not use radiation. It gives us the baseline anatomical information. Micturating cystourethrogram gives us further details of the urinary tract. When we require more details, we can use CT or MRI. And with 3D reconstruction, now it is possible to study the anatomy as well as the vascularity can be assessed with these studies. But the radionuclide stands add another dimension. They complement these investigations by telling us about the function. So all these investigations need to be decided based on the clinical condition, and they complement each other. They cannot replace each other. Like ultrasound needs a difference in reflectivity of the tissues to the sound wave vibrations. MRI need difference in protons, and CT imaging is based on difference in density. Similarly, nuclear medicine is based on a detection of difference in function and accumulation of the radio pharmaceutical by that particular organ and its excretion. By this way, it studies the function of that and structure of that organ. So through this presentation, I would be discussing what is the basic principle and procedure of a nuclear scan, the different radionuclides used, how to interpret them, and what are the applications in pediatric nephrology. So basically, the radiopharmaceutical is either administered intravenously or instilled into the bladder, like for DRCG. Time is allowed for, depending on the particular test we are doing, for the radio tracer to be concentrated in the kidney. And then the gamma camera is essentially like a CT scanner machine, on which the patient lies supine, and images are detected. The radiation emitted is detected by the gamma camera and the images are formed. It also shows the physiological function of the system, and advantage is it does not need any sedation, no allergies or hypersensitivity like to CT contrast. And sick patients can also undergo these tests, and these contrasts are also non-nephrotoxic. So we can use them even in patients who have impaired renal function. So this is the gamma camera, which is used at BLK hospital, and the right side image shows a pediatric patient undergoing a scan. So different radiopharmaceutical, before understanding which test which will be applied in which condition, we need to understand the principles. So the radiopharmaceuticals are handled by the kidney in different ways. Chromium EDTA, it is and technetium DTPA, dimercaptose triethylene pentacetic acid. This is primarily filtered at the glomerulus. So these are suitable for measuring the glomerular filtration rate by serial blood sampling after administration of this agent. By calculating its depletion in the plasma, GFR can be determined. Then there are agents which are handled by tubular secretion like orthoiodoheparin, MAG3, LLEC is L-ethylene dicysteine, and these are handled by tubular secretion. Mainly the tubules extracted and secrete them into the from the proximal tubules. So these can also be used to study the effective renal plasma flow. And then we have agents which bind to the proximal tubules like technetium DMSA and glucoheptonate. So they are helpful in studying the cortical imaging, in studying the structure of the cortex, because they bind to the proximal tubule and they stay there. So what indications can we think of? One is to assess the blood flow abnormalities like a captopril scan, which helps in assessment of renal artery stenosis, though due to availability of better angiographic techniques, we less frequently use this test. The next application is assessment of function, that is assessment of differential function, how much each kidney contributes to the function, and assessment of the glomerular filtration rate. Then obstruction in the urinary system, like pelviureteric junction obstruction or vesicoureteric junction obstruction, detection of pyelonephritis, uh, detection of vesicoureteric reflux, assessment of the renal function in acute and chronic renal failure, and assessment of renovascular hypertension. And also it is routinely used in DTPA scan is routinely used after renal transplantation within first week to ensure adequate functioning and vascularity of the allograft. So I will move on through, I'll try to demonstrate the use of these modalities with some case scenarios. A 4-year-old girl presented with recurrent UTI with bladder and bowel dysfunction. Ultrasound KUB shows normal sizes, right hydronephrosis, AP diameter was 10 millimeter. So as indicated, MCUG was done, which showed right grade 4 reflux and left grade 1 reflux, as it can be seen in the images very clearly. So in order to determine if this girl has renal scarring, what radionuclide to be used, and as I've already mentioned, there are 3 categories: filtered agents, agents excreted by the renal tubules, and cortical imaging agents. Anyone from the residents, which agent do we use here? And we want to detect renal scarring, whether this child has renal scarring. Vikram, Shoradeep, Chandrika. No one wants to answer. So, so we are going to use a cortical imaging agent, that is DMSA. So we are all aware of this algorithm given by the Indian Society of Pediatric Nephrology about the imaging guidelines in children with first and recurrent UTI. These guidelines are 10-year-old, they are being revised, though the imaging studies will be the same for recurrent UTI. However, there would be a change in the imaging in the protocol for after the first UTI, and these guidelines are probably going to be more conservative about the extent of imaging after first UTI. So early in summer next year, these guidelines will be published. Till then, we follow these guidelines. So this child underwent a DMSA scan. So what things we need to ensure before a DMSA scan? Child should be well hydrated so that the agent will be taken up by the kidneys well, and after the study, it will be rapidly excreted into the urine. And after the DTPA, DMSA is administered IV, we should wait for 2-3 hours for it to be taken up by the kidneys before the imaging to be performed. So this is one-time imaging and static imaging. It is a gold standard for detection of renal scars. The child has to lie supine under the gamma camera, and it rotates and takes different views. In the anterior view, right kidney will be on the right side, left kidney on the left side. In posterior view, it will be opposite. And then anterior and posterior oblique views are also taken. A normal kidney will have a very regular outline, and the kidney which is closer to the camera will be more prominent as compared to the other kidneys. So here the left kidney is more prominent because this is left posterior oblique view. Here in right posterior oblique view, right kidney is more prominent. This child did not have, this is a normal DMSA scan, this child did not have any renal scarring. Another child, this is a 14-year-old boy with UTI. He was operated for lumbar meningomyelocele, and he is a known case of neurogenic bladder. And now he was admitted with a urinary tract infection. He was not doing any clean intermittent catheterization or was not on any UTI prophylaxis. The ultrasound showed bilateral hydroureteronephrosis, left kidney was enlarged. MCUG showed bilateral trabeculated small capacity bladder with bilateral grade 4 reflux. A DMSA scan showed bilateral scarred kidneys. So what do scars look like? Here you can see there are photopenic areas where the kidneys have not taken up by the contrast. This is the liver shadow. This is the background background shadow, and in both kidneys you can see photopenic areas which becomes more clear, and the left kidney is enlarged, even the pelvic calyces system is prominent, and here there is the outline of the kidney is disturbed, there is loss of volume here. So these are renal scars, and the differential function of the right kidney was 36%, the left kidney was 64%. So this child is at risk of progression to chronic kidney disease if not appropriately managed. So previously, DMSA scan was recommended for diagnosis of acute pyelonephritis. However, now we should not do that. Now only late DMSA scan after 4 to 6 months is recommended for detection of renal scarring. The changes that we see in acute pyelonephritis may be similar. There are photopenic areas which may or may not lead to disturbance in the outline of the kidney, and the kidney may appear enlarged focally or globally because of the inflammatory reaction. And while in chronic scarring, the kidney outline is distorted and there may be wedge-shaped scars or loss of volume of the kidneys is evident. This is not 100%, but this is how we can differentiate. However, a DMSA scan for detection of acute pyelonephritis is not indicated. So what is differential renal function? When we do, this can be determined both from DTPA scan as well as DMSA scan. Once imaging is being performed, the region of interest is drawn around both the kidneys and in the background area. This is to detect the background radiation because some DMSA will be there in the other tissues as well. Then the radiation emitted from both the kidneys is calculated and corrected for the background effect. And in anterior and posterior views, one can calculate if both the kidneys combined function is 100%, how much of radioactivity is coming from each kidney. That is the differential function of that kidney. So here, the right kidney differential function is 48.9%. That means the right kidney contributed to 48.9% of the emitted radiation corrected for the background radiation, and left kidney contributed to 51%. In normal healthy kidneys also, it is not exactly 50-50. It might be plus minus 5 above or below. So a 3-month-old boy with antenatally detected bilateral hydronephrosis, since epidiameter was more than 10 millimeter, this child was started on cephalexin prophylaxis, and MCO showed bilateral grade 5 reflux. As you can see, there are bilateral dilated and tortuous ureters. And at 3 months, a DMSA scan was done where left kidney was poorly functioning. And here we can see the outline of the kidney is not disturbed as such. You cannot see a focal scarring, but overall there is global hypofunction of the left kidney. So this is likely due to the hypodysplasia of the left kidney, which has already happened, maybe due to reflux which has been present in utero. So vesicoureteric reflux may be detected in 2 ways, either during evaluation of a UTI, and these children usually have focal scarring, and further scarring may be prevented with antibiotic prophylaxis, and they carry a low risk of progression to chronic kidney disease or hypertension later on in life. While reflux detected during evaluation of antenatal hydronephrosis and with global hypodysplasia of the kidney, such renal function cannot be preserved even with prophylaxis or surgery, and these children have risk of progression to chronic kidney disease. If both the kidneys are affected, they are more at risk. So coming on to next case, this was the role of DMSA scan in UTI, and it may have application in other settings also. Like this 11-year-old boy presented with headache for 15 days. His vision was normal. He was not obese. There was severe hypertension, more than stage 2 hypertension, confirmed on multiple occasions. Ultrasound, Doppler were normal. Cardiac evaluation was normal. Kidney function test, thyroid function test, plasma and urine catecholamines were all normal. So then DMSA scan was done, which showed scarring in CT, and before that a CT angio was also done to rule out renal artery stenosis, because renal and renovascular causes are the most frequent causes of hypertension in childhood. There were multiple scars in the left kidney and MCO was normal. So this scarring was probably the cause of his hypertension in this child. So another role of DMSA is detection of congenital renal anomalies like polycystic kidney. Here you can see a moth-eaten appearance and a horseshoe kidney, and in you can also determine the function of each of the moieties of a horseshoe kidney: single kidney with a megaureter, ectopic kidney, ectopic malrotated kidney, and even multicystic dysplastic kidney, though we do not need now. But in MCDK, the DMSA will demonstrate absent functioning of the kidney, involved kidney. So indication, just to review the indications: detection of focal renal parenchymal abnormalities in after UTI, detection of acute pyelonephritis no longer indicated, detection of associated anomalies like abnormal duplex kidney, small kidney, dysplastic or horseshoe kidney, and confirmation of a non-functional multicystic kidney. These are largely the guidelines given by European Nuclear Medicine Association. So, next case, a 12.5-year-old boy is referred for evaluation of colicky pain in the this is right lumbar region. Ultrasound show left lumbar region. Ultrasound showed left hydronephrosis. Renal pelvis AP diameter was 20 millimeter with thinning of the cortex and dilated upper ureter. Uh, and he was suspected to have left pelviureteric junction obstruction. So what radionuclide can be used to evaluate his kidney damage? Filtered agent, excreted agent, or cortical imaging agent. Here we need to study the obstruction, confirm. Basically, we're doing this scan to confirm the obstruction. So a DTPA MAC3 EC, the agent which is excreted by the tubules or filtered at the glomerulus would be used. So this is also known as renal dynamic scan as against the static scan in DMSA, because here we are studying, taking images as the tracer is being taken up by the kidneys and excreted through the kidneys. So there are five parts: a perfusion panel, drainage panel, the curves, the T half of excretion of the tracer agent, and then differential renal function in GFR. We can get all this information from renal dynamic scan. All these three are also known as renal dynamic scan. So initially images are taken at the frame of one image per second, and in later half, that is to study the perfusion, and then they are taken at 1 minute interval to study the drainage function of the kidneys. So initial peak in the tracer agent is due to the perfusion peak. It happens within first 2 to 3 seconds, and then there is decline in activity. So in this scan, the left peak happened at, this is a normal DTPS. The perfusion panel is normal with peak happening in both the kidneys in 2.2 minutes and 2.23 minutes. Left T half was 3.5 minutes, and uptake in the left and right kidneys was also normal. So, and when there is in this scan, usually furosemide is also used to augment the drainage of the contrast. There are different protocols. Furosemide may be injected 15 minutes prior to the injection of the radio tracer, or at the same time, or after 20 minutes. So for this child, the perfusion graph, this black line curve is for radioactivity in the aorta, and the perfusion peak, you can see the blue line is for the left kidney, pink for the right kidney. The perfusion panel is okay, and in the later drainage panel, you see there is persistent contrast retention in the left kidney. And similarly, the region of interest, the calculation of differential function happens in the same way as I mentioned previously. And as you can see in the drainage curve, there is persistent radioactivity in the left kidney. There is retention of the contrast. So this child likely has left pelviureteric junction obstruction. Differential function was 67% of the right kidney and 32% in the left kidney. And the delayed images, one has to take delayed images when one is suspecting obstruction. So delayed images also showed continued retention of the contrast. So this is a child with pelviureteric junction obstruction, where this, but the differential function, you can see the graph going up instead of coming down. The drainage panel, perfusion panel is okay. But here the split function is 44 and 55%. The function of the kidney is not compromised. So what are the indications for surgery in PUG obstruction? Impaired renal function, as indicated by deranged creatinine, thinning of renal parenchyma on the ultrasound, and on adrenal dynamic scan, split renal function less than 40% in the affected kidney, or deterioration in renal function by more than 10% on follow-up, or worsening hydronephrosis, or presence of any symptoms like UTI, pain. These are all indications for surgery. So a 6-month-old girl with antenatal hydronephrosis, MCOG did not show any reflux. Here Lasix was given at 20 minutes. So for infants, since GFR in newborn period and infancy is low, it is maturing and it reaches the adult values only by 2 years of age. And also tubular function is immature. So one should consider doing these scans only after 6 weeks of age. And LLEC and MAG3 are better than DTPA in infants. So here you can see the perfusion panel is okay and the drainage panel is okay, that there is adequate drainage of the contrast. So these are non-obstructive hydronephrotic kidneys. So here the dynamic scan helped us to rule out any obstruction in the system. So this infant has right hydrouretry nephrosis and he has right vesicoureteric junction obstruction. One can see the dilated retention of contrast in the kidney as well as the ureter, and one can see the delayed drainage of the contrast. So this was a right vesicoureteric junction obstruction. Another scan which shows poorly functioning non-obstructed right kidney. Here the drainage curve is okay, but the function of the kidney is itself diminished. So the uptake of tracer, the perfusion peak, it is much lesser than that of the left kidney. So dynamic renal scintigraphy gives us information about renal perfusion, cortical function and excretion. And few things we need to remember. The trace is seen in the kidneys within 5 seconds in normal perfusion. The cortical peak happens by 5 minutes. A T half is normal up to 10 minutes. 10 to 20 minutes is borderline, and more than 20 minutes T half is delayed excretion. And MAG3 or EC are better than DTPA in infancy. So another application is use of a DRCG scan, which is the counterpart of MCOG for detection of vesicoureteric reflux. Here, by catheterizing the bladder, the contrast is instilled into the bladder, and then as the child voids, images are taken, and an increase in radioactivity in the ureter and kidneys is taken as it is more sensitive as compared to the MCOG. However, and the radiation is much less as compared to the fluoroscopy which is used in MCOG. However, we cannot identify the anatomical details which happens more clearly in MCOG, like tuberculations of the bladder, urethral anatomy, and also we cannot grade the reflux as specifically as we do with MCOG. And again, the catheter has to be used. So it is useful for follow-up study of reflux in children who are already detected having reflux with MCOG, or in girls where urethral visualization is less important. So there is one way to avoid catheterization also. Here the contrast is instilled intravenously, and after it reaches the bladder, this can be performed in an older child who can hold urine after it reaches the bladder and the child is asked to void. And in case of reflux, one will see a sharp peak increase in radioactivity in that side of the kidney. Like in this image you see, the contrast had appeared in the bladder, the kidneys have almost lost the contrast, and again as the child voids, a patch appears in the kidney that shows, in the right kidney, that shows right vesicoureteric reflux. So while reflux is graded from 1 to 5 depending on the dilatation of the ureters, major and minor calyces, here in with DRCG, we call it minimal reflux when the reflux is only up to the ureters, moderate it when it reaches the kidney, but does not show dilatation, and more severe reflux. So the grading is subjective. It is not as objective as in MCUG. Other applications which I would not be discussing is renal transplantation, assessment of GFR in the donor, and assessment of function of the allograft. Renovascular hypertension, we less frequently use this test. It can demonstrate the clinical what do you say, severity of that renal artery stenosis and trauma. So to summarize, nuclear scans give us important functional information about the organ of interest, and our basic knowledge of the physiology of the organ, and but one should also know the limitations, like LLEC or MAC3 is a better agent in infants, and one should not preferably do these scans below 6 weeks of age because of renal immaturity. And one needs to remember three class of nucleotides: um, filtered agent, excreted agent, and cortical imaging agents. And in dynamic renogram, one needs to look at the three panels: perfusion panel, drainage of function panel, and the curves, and obviously the differential renal function. So this is all. Thank you for patient listening. And if there are any questions, I can take. Any questions, clarifications?
Dr. Swati, can you hear me?
Yes, I can hear you.
You said that it is scans in the newborns are preferably done after 6 weeks of life. What
Yes.
are the challenges if they are done before 6 weeks? And if it is done before 6 weeks, does it need to be repeated again?
See, we do not do, see, a DMSA scan is never an emergency for assessment of detection of scarring. If you have even detected a reflux or PUV with impaired renal function, so we know we can assess the renal function by other methods, by urea and creatinine, and treatment can be determined. So DMSA scan is never an emergency. And the only application comes for DTPA scan for assessment of obstruction, like pelvic junction obstruction. Sometimes in the ultrasound, the AP diameter is more than 30 millimeter, 40 millimeter. You know, this patient is likely to require surgery. But again, as I said, because of renal immaturity, these agents have their limitation in assessment of function. So preferably they should be done only after 6 weeks. And if done earlier, mostly we do not need an early test, but if done earlier, MAG3 or LLEC should be preferred, not DTPA. Because GFR is as such low in the newborn period. So, and MAG3 and LLEC are secreted by the tubules.
Thank you.